Hello, and welcome to Your Health Matters. My name is Dr. Peter Hogenkamp, and I'm going to be your host today as we talk about the shared decision-making model. I was watching a old TV program the other day, and it was on one of those American movie channels or something along those lines. Anyway, this woman was in the room and waiting for the doctor to come in, and the doctor comes in and listens to her story and then examines her. And then he scribbles something on a prescription pad and hands her this, and he says to her, "Here, just take one of these and everything will be fine." And she smiles at him beautifully and says, "Oh, thank you, doctor, so much." And out she trots. And I got a big kick out of this because this is completely not what any kind of interaction that I have with my patients is like. But it was a great example of something that I like to call the paternal medicine model. And that is kind of doctor as this great paternal hero who's going to come in and solve all your problems and just tell you what to do. And if you just listen to what the doctor says, everything's going to be fine. That's the old model of medicine, the old paternal healthcare model. And we've been replacing it over the years with something that I like to refer to as the shared decision-making model. And you can look at this as the doctor is now forming a team with the patient. Patient and doctor are collaborating to come up with an outcome that's best for the patient, a decision for treatment or not treatment that's best for the patient. And to really understand what it is, you got to go back and think about how it contrasts with that paternal healthcare model. So, the best way to look at the paternal model, the old model, is that the patient is placing blind faith in the doctor and the healthcare system to improve his or her health. And the days of blind faith are gone. I think the internet is mostly responsible for that. The internet has been, as I mention all the time to my patients, the biggest boon and the biggest anchor around the ankle of medicine that there is. In other words, it's a wonderful thing for medicine and it's a terrible thing for medicine, both at the same time. Because it's wonderful because there's so much good information out there on the internet that helps us, that helps the patient, gives the patient information that allows the doctor and the patient to form a team and create a medical decision. Unfortunately, the internet is filled with crap. There is not only misinformation out there, but there is also the propagation of myths and prejudices that is one of the biggest things that's detrimental to this model, detrimental to coming up with a decision for the patient that's going to be the best outcome for the patient. Because in the shared decision-making model, ultimately the patient is making the decision about what care they're going to get, and if they are listening to a myth, or if they're allowing their prejudices to make the decision, then they're going to end up with a less than optimal outcome. And for that reason, the internet again is this two-edged sword, so good in so many ways, but again, in that it propagates myths and prejudices. It's very bad in that case. The other problem with the shared health decision-making model is that what the physicians have trouble with is time. When I was watching that little program I was alluded to, I think it was like a movie on American Movie Classics or something like that. The patient comes in, or the doctor comes in, talks to the patient briefly, examines the patient briefly, and writes something on a script. He was out of there in 30 seconds or a minute. That's wonderful for the doctor because the doctor probably has a busy schedule, but it's terrible for the patient. And so one of the biggest problems with shared health decision making is just the time that it takes. So there are problems with this approach, but when it's done right, it is by far the best way for a patient to receive optimal health care and feel good about that health care. Now, to illustrate what I'm talking about, I love to use stories. And we're gonna talk about some stories here. And we're gonna go back to a previous program in which we discussed the question, to be or not to be on a statin. And we talked about in a previous program that there are 3 absolute indications to be on a statin medication to lower your cholesterol. And those were having an LDL cholesterol greater than 190, the so-called severe hyperlipidemia, having known cardiovascular risk, for instance, if you've had a previous heart attack, or having diabetes. In these cases, the evidence is so overwhelming for the use of a statin, we call these absolute indications. That said, even in these circumstances, you can use a shared decision-making model. Because I have patients of mine who absolutely don't believe in medication, and even in these circumstances, for instance, I have a guy who's got heart disease, but he's so against taking statins, even though the preponderance of the evidence is overwhelming in favor of him taking it, he doesn't do it. And so we use the shared decision-making model in this case. He talks about his preferences and his beliefs, and I talk about the evidence-based medicine. And that's the key about shared decision-making. The job of the physician, who in this case is me, is to provide evidence-based outcomes. So, let's talk about it. What I tell this patient is, if you take a statin, this guy who has a previous heart attack, you are going to reduce your risk of having another heart attack by at least 30% and possibly as much as 50%. That's what the evidence suggests. That's what the evidence says. And so in his case, he says, I still rather not take it. Great. I simply write down on the piece of paper, we discussed it. He understands that he could be reducing his risk of another event by 30%, and he decides not to do it, and we move on. And that's the beauty of the shared decision-making model. But today I wanted to talk about the question about taking a statin, and I want to talk about it in a person who doesn't have an absolute indication for taking a statin. We talked about those 3 absolute indications: severe hyperlipidemia, known cardiovascular disease, diabetes. So now we want to talk about patients that are the bulk of the patients out there, patients like you and I, who have moderately high cholesterol. They don't have diabetes. They have no known cardiovascular disease. And this is millions and millions and millions of Americans. So let's say a patient comes in, and for the sake of the argument, let's talk about a really average patient. I've written down today the really average patient, and this patient is 50 years old. He does not have diabetes. He does not have cardiovascular disease. He does not smoke. He has comorbid hypertension, which means he also has high blood pressure. So the way we approach this is that I go onto my computer. We use computers in medicine all the time now. They're wonderful tools. And we type in for cardiovascular risk calculator. I want you to do this at home if you're watching. Or next time that you see your numbers of cholesterol, go into your computer, type in cardiovascular risk calculator, and click. The one I use is from the American College of Cardiology, but there's a number of websites out there that have it. It's all based on the same information. And this data has been basically comes from the thousands of studies that have been done on cardiovascular disease, starting with the Framingham study many, many years ago and continuing on to the present day. And what it does is it gives you a 10-year likelihood of you developing a cardiovascular outcome. So when we type in this 50-year-old patient who doesn't have diabetes, doesn't smoke, is overweight, has hypertension, we find that this patient has an 8.4% risk of having a cardiovascular problem in the next 10 years. So, as I said a couple months ago in the program when we talked about this, if you have less than 5% 10-year risk, that's considered to be low. Nobody is going to recommend a statin for your cholesterol in these circumstances. If you're between 5 and 7.5%, it's considered to be borderline. 7.5 to 10%, it's considered to be intermediate, and above 10% is considered to be a high risk of cardiovascular disease. Keep in mind now, I have some patients when I put them into the calculator, and we're talking about 70, 80% risk, 80% 10-year risk. There's people out there with these high of a numbers. Those patients, again, it's an absolute indication to take statin. Now, that doesn't mean they're going to do it, although the large percentage of them will. But I wanted to talk again today about the intermediate risk, the borderline risk, anywhere from 5 to 10% risk of 10-year risk of getting a cardiovascular outcome, such as a stroke, a heart attack, having a stent placed, getting CABG surgery, having a carotid routed out. All right, these are the things we're talking about. And I guarantee you, every person who's out there watching, whether that be on PEG TV, the PEG TV YouTube channel, or the Your Health Matters YouTube channel, either you yourself have had one of these outcomes, or you know somebody that has one. A dad, a mom, a brother or sister, a child, a friend, an uncle. Very, very likely, because 40% of Americans have these problems. You know a lot of people with these issues. And I mentioned the 40% figure because I want you to keep in mind that this is not a hypothetical issue. This is an issue that we all are very, very likely to deal with on a daily basis, either through our own health or dealing with a friend or a relative. This is the #1 killer in America, cardiovascular disease. So I want you to keep in mind one of your loved ones when you're doing this, because I think it makes it more real and kind of gets it away from the realm of just a numbers game kind of thing. But anyway, speaking of numbers game, let's go back and talk about this patient, this 50-year-old, who has an 8.4% cardiovascular risk. So the patient comes in to see me, and he says to me, "All right, doc, you got my numbers, and how did I do?" And so what my approach in this case is, just to kind of give him the numbers. Here are the numbers. Your cholesterol is so and so, and we type it into. I show them. I bring my computer out, show them what the calculated number is, because I think the visual of it is very good for people. And I'll say to them, "All right, you're 8.4%. This is the perfect scenario for shared decision making. There's no absolute indication for medications, but there's a relative indication here, for sure, because we know that by putting this person on a statin, they're going to see a 30% risk reduction in their cardiovascular disease outcome. 30%, only by taking a statin. Now, they can increase that risk reduction by doing all kinds of things, losing weight. If the patient was smoking, in this case the patient wasn't a smoker, but if the patient is smoking, you can have them quit smoking, you can change their diet, you can increase their exercise. The total package, as I like to say, you can reduce patients' risk of cardiovascular disease 75%. It's been done many, many times. But that's the total package. And the question we're talking about here today is whether or not the patient was going to take a statin to lower their cholesterol. But I wanted to remind you that this is not the only thing that we can do to reduce your cardiovascular risk. It is, by far, the single most important thing that you can do to reduce your cardiovascular risk other than quitting smoking. If you're a smoker, simply by quitting smoking, that is the major cardiovascular risk reduction. Outside of that, the next most powerful way to do it is to take a statin. Millions of Americans take statins. Millions of Americans take statins because there's so much proven benefit to them. That said, a lot of my patients, especially here in Vermont, they simply don't want to take a medication. They want to kind of do this the natural way. They want to do this by themselves. And I always support that, because if you take a medication to lower your cholesterol, it will work. It will reduce your cardiovascular risk by 30%, as I mentioned again and again. But your weight isn't going to be affected. Your exercise level is not going to be affected. Your sugar is not going to be affected. If, on the other hand, you want to do this, by diet and exercise, all of these, your weight goes down, your blood sugar goes down, your blood pressure goes down. So the natural way of doing it is a wonderful thing. Now, the other thing I like to keep in mind is these things are not mutually exclusive. We can have a patient take a statin and we can have them do lifestyle changes, and together you get a significantly higher reduction in your cardiovascular risk. So why do we choose one or the other? Well, again, in the shared decision-making model, it goes back to the patient's preferences and beliefs. It also goes back to the patient's, kind of motivation and their inclination to be healthy. I use that word all the time, this inclination to be healthy. Unfortunately, many Americans have no inclination to be healthy. The obesity rate is 60% and it's going higher every year. The rate of diabetes is going higher every year. It's been said that by 2025, every third American adult, 18 and up, will have diabetes or some type of impaired glucose tolerance. 30% by 2025. We're almost there. The numbers are inching towards that. If they keep going, I can't even imagine what it's going to be like by 2030. So if our obesity rate's this high, if your type 2 diabetes rate is this high, what is our inclination to be healthy in this country? And in Vermont, fortunately, where we have a very healthy-minded population, we're certainly not perfect, but we have a healthier-minded population. There is more of an inclination to be healthy than there is in the rest of the country. But the reason I bring this up is because time and time again, I have the same conversation with patients. And we go over their numbers. They sit down with me, at their physical, we go down over their numbers, we see their cardiovascular risk, and the patient goes to me, doc, I really want to do this on my own. And I'm like, listen, that's wonderful. But we have said the same thing over the last 10 years. And I've been practicing medicine here in Vermont for almost 30 years. I have documented discussions with patients that go back 25 years. Talking about, I'm going to get this done, but they don't. And at some point, you have to just bite the bullet and say, listen, I've given you a long time to do this. You're not getting it done. I would love for you to lower your cholesterol, via diet and exercise. Nobody would be happier than me, because, as I mentioned before, so many things are going to happen with the doing it the natural way through diet modifications and exercise. Your blood pressure is going to be better. Your mood is going to be better. You're happier. Your sugar is going to go down. All these, your cholesterol is going to go down. So many things, so many good outcomes that you get out of achieving, the lower cholesterol through diet and exercise. But the issue is, if it's not happening, it's not happening. I always give people a chance. Again, outside of the three absolute indications for taking a statin, I'm very kind of a patient advocate kind of doctor. I give people chances and chances and chances. Now, what happens in many cases is, we're talking about 10-year risk for cardiovascular disease outcomes. I'll have this conversation with the patient, have this conversation with the patient, have this conversation with the patient, and then all of a sudden he comes in with chest pain and I do an EKG and he's having a heart attack and off he goes to the hospital. And then he comes back after they take care of his heart attack in the hospital. He comes back to see me in a month and he'll say something along the lines of, well, I guess I should have taken that statin. And then as we move forward, I'm like, well, listen, let's move forward. Let's take the statin. Let's modify our exercise and go from there. So ultimately, and this is not a freak occurrence or an unusual case. As I mentioned, 40% of Americans die of cardiovascular disease. So these are outcomes that happen all the time. That's why this conversation is so germane, so relevant, because it's all over the place. It's happening. It's going to affect you. There's a 40% chance that you, whoever you are, will die of cardiovascular disease in this country. 40%. And by taking a statin, remember now, you can lower your risk of cardiovascular disease by 30%. That's just all comers. Anybody who takes a statin, they lowering their risk of cardiovascular disease by 30%. So there's this, going back to what I was talking about, this, we want to consider the patient's beliefs, their preferences, but we also want to consider their inclination to be healthy. Now, some patients especially here in Vermont, they're very, very motivated. I've seen amazing things happen with people with cholesterol. I had a guy, I told this one guy he had a very high cholesterol, and I told him that the maximum that you could do to lower your cholesterol was a 35% reduction. And that's the studies really bear that out. Diet and lifestyle modifications really can lower your cholesterol about 35%. So this guy goes, oh yeah? Well, he went out and he did an absolute and total complete lifestyle modification, changed everything he ate, he meditated, he walked, he ran. This guy lowered his cholesterol by 40%, just lifestyle modification. So he was able to kind of go above the maximal thing, and I was so pleased. But there's a but here. Keep in mind, there's a but coming. But when he came back a year later, his cholesterol was even higher than ever. And that's when I talk about the area under the curve. And what do I mean by that? It means that for one blip in time, this gentleman was able to get his cholesterol down very close to goal with maximal effort. And again, I was super proud of him, and I think it shows, how powerful these lifestyle modifications can be. But he was able to achieve it for a very, very short period of time. In fact, what he later told me was, as soon as he came in and got those numbers, he left my office and he went out and got breakfast, with sausages and pancakes, and that was the end of it for him. He came back a year later and he was shocked to find out that his numbers were that high again. He thought he'd cured the problem, but he hadn't. What he had done is he had gotten his numbers in line for one blip in time. And so when we're looking at the area under the curve, as time goes on and his cholesterols are very, very, very high, he had it lowered for a very short period of time, but then it went right back up. And this area under the curve, this massive amount of this is the time that his arteries are exposed to high cholesterol. And when you add up the area under the curve, it ends up with atherosclerosis, no question about it. So I love lifestyle modifications. I love them. But they are only good if, number one, you are going to do them, and number two, you're going to sustain them. So when I check cholesterol, let's say a patient comes in, and this 50-year-old patient we're talking about with this 8.4% risk, 10-year risk of cardiovascular disease, and the patient goes, I'm motivated to do this, doc. Let's get back in a month, then we'll do this. And I'll say, no, we're not going to do that. Number one is the insurance company doesn't want to pay for his cholesterol again in a month. Number two is anyone can do anything for a month. They can. Look at like the Whole30 diet, which is a very, very popular diet that people use. People want to do things for a short period of time, and then they want to go back to their old ways. And that, as I mentioned with the area under the curve theory, it doesn't work. You've got to do these things, and you have to continue to do them. So what I tell patients is this: listen, go out and live as healthy as you can in a manner that you are going to be able to sustain for the rest of your life. Not for a week, not for a month, for the rest of your life. It's interesting because years ago I bought a cholesterol machine for the office, and we were able to get people's cholesterol very accurately with just a poke of their finger. Their blood would go into a little capillary tube. We'd put it into this machine and we'd give them their cholesterol. And we ended up stopping using it for some reason. I don't really remember, but we had the machine. I had all these cartridges left. So I was having a lot of fun with diet at that period of time, and I would go on these diets for a week and just to see what the effect was on cholesterol. And the reason I'm telling you this story is because I was able to change my cholesterol significantly based on 1 week. We used to tell people, it takes a long time for these changes to happen. It doesn't. You can modify your cholesterol significantly within days. It's amazing how fast this happens. And I proved this with my own cholesterol machine. Ultimately, I ran out of cartridges, so I stopped doing it. And then I realized to myself, I'm eating oatmeal every day. I'm eating oatmeal 3 meals a day, and my cholesterol is fantastic. But am I going to live on oatmeal 3 times a day for the rest of my life? I am not. I can tell you I am not. And you have to keep in mind that food is one of the great joys of living. And I always keep that in mind with my patients. I'm like, listen, I want you to go on a diet, but I want you to still enjoy what you eat. I look forward to breakfast. I look forward to lunch. Maybe I'm more food-centric than everybody else, but I doubt it. I think most Americans like to eat. And that's a wonderful thing. It's one of the great joys that we have on this world. So going back to my patient, I want you to get on the healthiest diet that you can sustain, that you can keep up forever. Because it's one thing to lower your cholesterol, and it's another thing to do it for the rest of your life, or even a significant amount of time, 5 or 10 years. I have many patients who are able to do these things. It's amazing to me how strong-willed and disciplined I have some patients. But they are not the majority of patients. The majority of patients can only do things for a short period of time. So if you want to do this by yourself, kudos to you. I think that's wonderful. You just got to make sure that you sustain this for the rest of your life. In the short time that we have left, I wanted to just talk about some of the changes that we can make on a health style basis that patients can choose to do in the shared decision-making model. So obviously, number one would be quit smoking. As I mentioned, smoking is the number one cardiovascular risk reducer. Nothing that you can do, nothing, will lower your risk of cardiovascular disease more than quitting smoking. Now, I realize it's difficult, but keep those numbers in mind. It is the number one most effective way to reduce your cardiovascular risk. Weight loss. Weight loss is a great way to reduce your cardiovascular risk. Unfortunately, Americans struggle with this. Our average weight of the American goes up and up and up and up. I'm interested to see the new data that comes out shortly about this because of the effect that all the GLP-1 antagonists have had. I think you all know what I mean by this. These are the medicines like Mounjaro, or as I like to refer to it as Kilimanjaro, Ozempic. There's a lot of them out there. There's more coming out all the time. Ozempic and Mounjaro are the two that I use most frequently. These are very, very effective diabetic medications that are also indicated for weight loss. Wegovy, perhaps you're familiar with that brand name as well. And these medications are very effective. They're widespread use now. Such widespread use, in fact, that it's hard for some of my patients to get them. They can't make enough of it. And I'm wondering whether the widespread use of these GLP-1 antagonists has actually lowered the average American's weight. But that data is coming out soon. We'll talk about that in a future program. Exercise. Exercise reduces your risk of cardiovascular disease, even when you're not losing weight. So if you're exercising and you're not losing weight, as most people that exercise don't, because as I've said many, many times before, and I'll mention it again, exercise is a great way to maintain your body weight. Maintain your body weight. Because when you exercise, it stimulates your appetite, and you tend to eat the number of calories that you've burned, and it's a zero-sum game, which results in your weight remaining the same. If you're trying to lose weight, you have to reduce your calories no matter what. And this is something people say to me all the time. I just haven't been very active this winter. I've gained some weight. It's like, it's not about activity. It's about eating. That's very, very clear. I'm running out of time. I just wanted to mention a couple of these things quickly. Obviously, treating your hypertension, lowering your sugar. These things are all very important. So just in the half a minute we have left, I wanted to just go over the shared decision-making model, which you should be practicing with your physician. Your physician should be giving you the evidence-based outcomes, and you should be discussing your preferences and your beliefs, and you should come together to make a decision that's best for you. Thanks again for your attention and participation today. Please go to Peter Hogenkamp's Your Health Matters with Dr. Peter Hogenkamp. If you want to see some previous episodes, make sure to share them with your friends. I really appreciate your support, and I look forward to seeing you next week. Cheers.